Welcome to another episode of the PD Exchange. I'm your host, Dr. Nikhil Shah, and with me, as always, is my co host, Dr. Jeff Perl. And together, we bring you the important conversations shaping the world of peritoneal dialysis. I am a nephrologist and the peritoneal dialysis director at the University of Alberta in Edmonton, Canada. And Dr. Perl is the staff nephrologist at the St. Michael's Hospital, University of Toronto, Canada. He is also the current editor in chief of Peritoneal Dialysis International. Today, after a brief hiatus, the PD Exchange podcast returns to shine the light on a topic central to our patients' quality of life: exercise and peritoneal dialysis. For today's discussion, we are joined by a powerhouse panel of experts whose research, advocacy, and clinical experience are transforming how we approach physical activity in kidney care. Let me introduce our guests. Dr. Stephanie Thompson is a nephrologist and a dear friend and colleague at the University of Alberta. She is the medical lead of the North Alberta Renal Exercise Program. Dr. Thompson's research focuses on using exercise interventions to improve outcomes for people with chronic kidney disease. Dr. Clara Bohm, she is a nephrologist at the University of Manitoba and the medical lead for the Manitoba Renal Program Exercise and Wellness Program. Dr. Bohm is a leading researcher on the impact of exercise in CKD, with special interest in improving quality of life and overcoming barriers to physical activity. Dr. Paul Bennett, he is the deputy head of school in research at the Griffith University in Australia, and he is internationally recognized for developing innovative strategies like resistance and aerobic exercise to boost quality of life in people with kidney disease. We also have another guest who may or may not join. She's on service, Dr. Jennifer McRae. She's a nephrologist at the University of Calgary and the medical director for the Alberta Kidney Care South program. Her clinical and research focus is on optimizing care for hemodialysis patients and advancing patient-centered research in kidney health. And with that introduction, I will hand it over to Jeff.
Thanks, Nikhil. And yes, it has been a bit of a hiatus. And I think this topic is really interesting because we're actually going back to something that, has been published earlier on. I think that probably predates the podcast, and that's the GREX guidelines on exercise and peritoneal dialysis, which I think were really well needed. And, maybe, Paul, you can tell us a little bit about them, how they came to be, and maybe describe some of the key features of the GREX guidelines.
Thanks, Jeff. Yeah, I think we really noticed it over about 5 years ago. There was a real dearth in the focus on PD and physical activity and exercise. There's been a lot of hemodialysis focus. Hemodialysis patients are a lot easier to get to, a lot easier to research, a lot easier to talk to because they're stuck on a machine and we can go and visit them and recruit them. But as far as PD was concerned, there have been very few studies in PD exercise programs and physical activity. So we looked at what we can do. The first thing we do is we ask the question of our consumers and our care partners on PD, and they said, what do you think? And most of them said, we have no idea. We have no idea. And no nephrologist or no nurse has given us any idea. We ask questions, but we really don't know whether they know what they're talking about because as clinicians, they're experts in the kidney and dialysis, but not so much in exercise. So they've looked externally and we thought, well, we should do something about this. So we looked at guidelines for from other exercise groups and other PD groups and realized there was a real missing area. So we went about it. It was a 2-year process. And we got to a stage where we approached it from a patient perspective, where the patients asked the questions: can I swim? What happens when I sweat? Can I lift weights? Can I walk the dog? All these questions that are normal active questions. And so that's where we started from. We ended up getting sort of 4 big domains around what do you do around when your catheter gets inserted? What exercises can you do there? Should you exercise dry or wet? What do we do about core strength? What do we do about sexual activity, frailty, mental health, obesity? A lot of the issues that the day-to-day person on PD has to deal with.
Yeah, these are really important issues. And, I think what strikes me is how little evidence we have to give our patients and how little we do discuss about exercise. I think sometimes I feel I'm really good at pill pushing, and, doing the doctory things, but, I have yet to prescribe exercise. So let's start with that. Is there data? Maybe we'll ask you, Stephanie, and then we'll come back to the Grex guidelines and go into a lot of the things you said in a little bit more detail. I want to tease out the swimming and the lifting because I think they're still controversial, but you'll give us some of the data around that. But maybe to ask you, Stephanie, is there data in CKD and in patients on dialysis that prescribing exercise actually improves outcomes?
It depends which outcomes you're talking
Right.
about, right? So I think it's fair to say that we can say that exercise improves physical function. So things like getting up from a chair, strength, walking, pretty basic fundamental things to remain independent.
Yeah.
And we've shown that in a number of CKD populations, people on dialysis and so on. We've also showed that exercise, and Clara has a systematic review that she published with her group a number of years ago in CJSON, showing that exercise can certainly alleviate symptoms, which are a very important outcome for patients, particularly depressive symptoms.
Yeah.
Yeah. And so, I think it's a great question because we do know, and we can tell patients, like, we're not just extrapolating from the general population with those outcomes anymore. So things likely fatigue, many of the domains of quality of life, physical function, depression, maybe cramps, maybe restless legs. There's good evidence from trials to show that we can improve those things with exercise. And so now we're asking what else? And so, again, Clara's looking into the effects of doing dialysis and cycling together, intradialytic exercise, and the effects on the cardiac stunning. Like, how else can we use exercise to improve outcomes? And I really think that that's where the field is heading. We know that we can improve physical function and fitness, but what are some of nephrology's concerns? Like the day-to-day nephrologist talking to patients in clinic. And I think you need nephrologists more involved in the research to really call out those things.
Yeah.
I don't know how many nephrologists are impressed by improving VO2 max. I mean, it's associated in other populations with survival, but we want to know about things that we have to counsel patients on, like heart.
The thing that I find absolutely baffling is, and then I'd like to hear your perspective on this, Clara, about what we know about exercise improving outcomes. But the thing that I find absolutely baffling is that you talk to many nephrologists, they're cycling, they're biking, they're going to the gym, they're doing all this stuff. And I'm always amazed. I go to the gym, and at least I try to, and I feel better, and I have a lot more energy for the day. Why aren't we actually telling our patients to do that too? So it's I think it's just such an interesting dichotomy about how I think many nephrologists are incorporating exercise into their lives routinely, but I think it's not something we talk about a lot with our patients. So Clara, you were going to chime in here on some of your thoughts.
Yeah, I have so many things to say now. So I was going to say that it's actually why I started exercise research, is because I get so much gain from exercise, and a lot of chronic conditions, not just kidney disease, but have mental health problems, physical function problems, all things that should be improved with exercise or are known to improve in the general population. And I think we do have evidence now that in the dialysis population, particularly, that they also improve things. Now, the studies that Stephanie was talking about were particularly directed at hemodialysis, but there is a Cochrane review recently that also found almost exactly the same findings as we did, and that included peritoneal dialysis populations and participants as well. I think there's a real paucity of studies of exercise in peritoneal dialysis still, and for the reasons that Paul mentioned. But I do think that really one of the reasons why we don't prescribe it or we don't talk to our patients about it is because we aren't taught about it. And we're not, as physicians, we don't like to talk about things we're not sure about.
Yeah.
I think so. So there's two solutions to that. The immediate solution is that we shouldn't be actually talking about it. Maybe we're not the ones that should be prescribing it. And we know that exercise professionals and exercise experts do a great job of doing that. People like exercise physiologists, kinesiologists, physiotherapists.
Yeah.
The second thing is education, of our medical trainees and nephrology fellows should include this. And we've started to include a half day in our fellowship program on exercise every other year so that people get some exposure to exercise.
That's
I'll
really
stop
great.
there.
Yeah, no, that's really great. And I was just thinking, as you were saying, like, when a patient comes to me and says, I want to reduce my phosphate or my potassium's high, I don't know the first thing about what to tell them to eat or not to eat. So we have a dietitian, and their
Yeah.
job is the nutrition piece. And there's a gap, actually, I think, in our allied care circles. Nobody can call. I'd love to be able to say, well, let's call upon our exercise specialist, be it kinesiology or physiotherapy or whatever, somebody on the team who's versed in this to help a patient start an exercise program. And I think another barrier might be fear that we actually, could injure our patients if we're not telling our patients to do things in a more supervised way. So I absolutely agree about your point about a lack of knowledge and an ignorance about the issue means that, we're more comfortable not talking about it than talking about it. Stephanie, you were going to say something too.
Yeah, I mean, I agree with all those points, and certainly those been shown in surveys. But I think with exercise, what's really interesting is is this other layer. And it's because exercise is a socially desirable behavior that, if you as a healthcare provider aren't exercising, there can be a bit of a, well, if I'm not exercising, how can I tell somebody else to exercise? Or
Right.
it's weird. And I think that we do have to get over that. And it really comes into how you relate to the person about the behavior rather than telling them to do something, even though you're not.
Yeah.
But it is funny about exercise. So there is another layer that I think makes people uncomfortable other than knowledge.
Yeah. Yeah. And there's knowledge, there's fear. And, Clara, you were going to tell us a little bit about a story that you were involved in.
Yeah, so I think now, with the experience that I have in terms of programs we've implemented clinically and on all the research I've done, I think that anybody can do exercise, or almost anybody on dialysis. It just is what we consider exercise and what type of exercise. So it's at their level and it's individualized. But when I started all of this, and particularly as I was thinking about the cardiovascular impacts in our population that has a high cardiovascular disease burden, I started listening to Dr. Chris McIntyre's talks at some of the meetings where he was talking about stunning in hemodialysis patients during dialysis. And I wondered, oh no, like I've got all these programs going on. What does exercise do? And I actually approached him and we did a project together, which then showed that it decreases stunning if you do exercise during dialysis in a cross-sectional study we did. And subsequently, there's more evidence now that it actually improves stunning in hemodialysis. But this is all just to say that, I actually pursued this course, but it could have been the end of all my research, because if it had caused harm, then we would have been in trouble. But the good news is it doesn't cause harm, and it may actually cause benefit. So, yeah.
Right. And speaking of it, we're using the term exercise here. Now, Paul, there's different types of exercise, correct? There's strength training exercise, there's aerobic exercise. Can you take us through our approach to that and what type of effects we might expect different types might have on our patients?
Yeah, sure. I think that any exercise or any physical activity, and there's that physical activity exercise sort of terminology that we all play with. If we call it physical activity, we know it's exercise if we prescribe physical activity. Right. But I think what's really important is that for any consumers out there, that any physical activity, as long as it's safe, is great. And we often it's a sort of a slope, isn't it, where you can get exercise, which is basically a prescribed physical activity, versus the broader physical activity, which is pretty much anything that we do that we use our muscles and skeletons for. So, as far as the studies around aerobic versus resistance, you'll always get a bit of resistance within aerobic. If you do cycling, you'll get a little bit of resistance. You'll always get a little bit of aerobic with resistance. If you do weights, there is some aerobic component to weights as well. So it's not one versus another. It's what you prefer and what is best. So I don't look at it as a should you do aerobic or should you do resistance. You should do what suits you. If you like going to the gym, you go to the gym. If you like, if you have a gym around you, and many people don't, which is a real problem. So it's what you can do. And I think that's what we're coming to. And a lot of the studies around, what's the exercise that you do that will be best for your life and your quality of life. I think that's the way to go about what we're doing. Prescription is great, but very few people, well, some people on PD, are unlikely to be able to follow a prescription just because they've got such a busy lifestyle and they have different values maybe, or they have the same values of wanting to stay healthy and as possible. But the values that we hold, where we can just go to the gym after work, or we can do, it's almost impossible for a lot of these people to do that. They don't have the capacity to do that, and they feel I'm different. I'm not normal. I've got this catheter hanging out of my stomach, and really, who's going to sort of think? And I'm scared. I think there's a lot of fear in people on PD around doing what they can't do. And without the research that we're trying to get done, that fear is really hard to allay, because we haven't got some really, really good fundamental trials that show that pretty much it is safe. There has been work done that shows that mostly safe, and we're continuing to try to do that to add to our knowledge.
Right. And so basically the point you're trying to make is any exercise is good exercise. And to take somebody who may have a hard time getting into a particular gym routine or whatnot, anything that's sort of feasible and that they enjoy doing is probably something that we should encourage. Do you have any examples of how you incorporated that for patients?
Yeah, sure. And I think there's some good examples in Canada. I'm always amazed by you Canadians, and I can say that in this group, is that you're a long way ahead of a lot of other countries when it comes to exercise with our universal healthcare systems. I don't know how you do it with the cold weather that you do. I've seen Clara
was going to bring that up. I was going to.
I've seen Clara in her suits with her bikes, with her spikes on her tires, and I'm like, oh my God. So in Australia, we don't have those problems. In a lot of other countries, we don't have the problem. So I was amazed. Getting back to the question, Jeff, sorry, after going off on that tangent, I think as long as it's safe, and because we're scared, and as a PD, so I'm a PD nurse. As a PD nurse, the Tenkoff and the abdomen and the peritoneum is their lifeline, and I am so protective of that, and most of us are. So we have to sort of balance that with allowing and encouraging people to do what they can. There is absolutely no research around when you can do exercise after you put a catheter in. And we're doing that now, and hopefully we'll have some information and some results by early next year. But that really important bit where you said, okay, we've booked you in for a Tenkoff catheter, we're going to start you on PD, blah blah. Those 2 months or so, what happens to that person's physical function during that time? And I can tell you, it decreases hugely. We've got unpublished data that shows that decrease in physical activity in those first 6 months of PD. It's shocking. Yet we don't do a lot about it because we don't know how to go about it in a way. And that's to Stephanie's and Clara's points where exercise professionals can help us there.
Right.
I think Paul has highlighted that, and he said it at the end, like really having somebody to motivate people and alleviate their fear and guide them through the exercises, which is not what PD clinicians, either nurses or physicians or allied health, can do, because they're there for another job, is very, very, very important. And I think, we've solved that problem somewhat by doing outpatient classes. We have a medical fitness facility that we partner with, 2 different medical fitness facilities, and we offer the classes there led by kinesiologists. And that provides supervision. It provides education on all the equipment in the gym that people wouldn't understand and safe use of it. And then in addition to that, it also provides social contact and socialization. And I think that's also another thing after really a really important thing is the social aspect of doing exercise and getting together with people, which helps with mental health and belonging. So, Nikhil, you are a very funny person. Can you tell me what you're thinking?
What I wrote in the chat. Well,
Yeah.
you did mention about having the accessibility to weights and going to the gym and people not being actually able to go because of so many reasons. You are doing PD. You probably could use one of those bags as weights. That's one part. But what I was actually going to really say was when we teach our residents and fellows as they are rotating through home dialysis or any kind of dialysis, we have that structure, a format. You ask about anemia, you ask about CKD, MBD, and all of that. And we are the end of it is transplant. We really need to encourage adding exercise and physical activity and maybe even life participation as items that need to be discussed as part of your routine clinical follow-up.
I've started adding it to my review of systems when I can, and it doesn't always happen because it's busy sometimes, right? And it hasn't become routine yet, but I've started adding whether they use mobility aids, how many, if they do their activities of daily living or not, and if they're active or not into my review of systems.
Yeah, same. I think it's just like in terms of training, important to talk to people about how to talk to people about that. Because you can't make people defensive, right? If, yet again, it's something else that you're not doing. Like we've already chided you about your potassium and your phosphorus, and now we're heading for exercise. So I think it's really nice if you can phrase it in a way like, do you have the opportunity for movement? Do you enjoy it? That type of thing. And it can be relational. Like I know it's busy, but it's a good opportunity too.
Yeah, and as you're talking, I'm thinking about it, and it's that going to the gym for even somebody not on dialysis for the first time and getting into an exercise program can be pretty daunting, right? Like you see all these people, like you don't know exactly what you're doing, and it's quite daunting even for the general population. Take a disability, take a medical condition, take that fear, and you're just adding a level of complexity. And I'd say another gap is that we have limited resources where to send our patients to get that sort of supervision and guidance. And I think just as we've I think it sounded interesting what you were saying about the medically supervised classes that you have access to. I mean, I don't think that's everywhere. And I think that that's something that I would love to be able to send our patients to and also help. Oh, go ahead.
That's actually something that our program pays for. Like they're free classes for the individuals, and so I think that's really talking about using your resources in a different way. And interestingly, there's a paper that just came out in the Translational Journal of the American College of Sports Medicine.
We only talk about PDI. No, I'm just joking.
I know. I'm sorry. It doesn't even, unfortunately, it doesn't even have chronic kidney disease, but it looks at cost effectiveness of supervised outpatient exercise programs in people with chronic diseases. And kidney disease wasn't one of the chronic diseases they included, but they showed that for every dollar spent on the exercise program, there was a cost savings of up to $1.70. So it really actually makes a huge difference. And I think that is another important evidence gap in nephrology is showing that these types of programs are actually cost saving in the long run. So, and cost effective. Yeah.
Yeah. No, that's a really also an important angle to look at.
Yeah. Just to the point of what can encourage or motivate people who are tired, who are busy, who have, if they're on COPD, they're doing 4 times a day. If they're on APD, they spend all night in bed. What can we, put ourselves in their shoes? And it's really hard for us. We can say we can go to the gym, but put ourselves in their shoes. But I think one of the huge things that people tell me around their PD is they don't want it to fail. And they want to continue on. They've been through this. They're used to it. They love not having to go into hospital. Some still like going to hospital, but most love and desire that independence. If they lose their physical function, if they can't move the boxes around the house or the other consumables that get delivered around the house, if they can't have a nice place, if they can't even pick up their bags, they're not going to continue on home PD if they don't have the support. So this is not just about quality of life and about everything that's important to patients. The importance and the cost to both the person and to the health is them not continuing on PD and coming off PD and having to go on in-centre or having conservative care or even the potential of going to home hemo. To maintain them is maintaining this independence, which is something that I think is really important. If we're serious about that, we support both their mental health and their physical health. And of course, you can't separate those. So right. I think that independence piece and putting ourselves in their shoes and knowing that, in fact, to participate as an independent PD person, you actually have to be able to move things and to lift things and to walk
right.
around.
So let's take a step now and get into a little bit of the nitty gritty of some of the details. And you mentioned, Paul, at the beginning, you talked about swimming. I just was going to say, what is the party line on that? Because I can tell you, as many PD units as there are out there, the guidelines and the discussion about swimming is so variable. And I have to say that patients ask about this all the time. And actually, when thinking about PD, it does come up. My analogy to patients is like, when people are looking for a house, they say there has to be like a bathtub in the principal bedroom. But like if you actually ask how many times people have actually taken a bath in that bathroom, it's like once a year, if at all. And I feel like the swimming thing comes up, and maybe people are swimming every day, and that's great. But the amount of times that swimming comes up, it'd be interesting to know how often people do swim. But what is what is your advice and about swimming? Let's just get into that.
Sure. So both the advice of a consensus group, which includes patients, nephrologists, exercise physiologists, and added to the surveys that Dr. McRae and others on this panel have done, is that people will swim. People will do what they're told they can't do because it's in your mind. The prevalence of who swims, of how many PD swims, I don't think we know that, and it would vary from Canada to Australia, I'm sure. Yeah. But be that as it may, swimming is common sense. So yes, you cover it. We can use a colostomy. We recommend using a colostomy bag over the top or something that's particularly prone to that, and definitely exit site cleaning. Swimming in a polluted river somewhere maybe in a low-income country is a whole lot different than swimming in a very clean municipal pool or even a backyard pool. So it's about common sense, and it's about what and I think we have to provide that information to people. We have to provide the principles in if you're going to swim, and we have to allow for them to be honest to us when we're talking to them and not say, you can't do this, you can't do this, you can't do this. Instead asking, what do you want to do? Which I'm sure most nephrologists and most nurses do, but I think we also are a little bit defensive when it comes to, well, you can't do this. So in the survey that we did, and I think the survey that Dr. McRae did, is that like, it depends where you are in the world. You say you can't swim or you say you can swim, and even within regions in cities, excuse my dogs in the background, you can, there's different in opinions. We interviewed about 10 PD patients only a couple of months ago, and 5 of them, and this is in Australia, 5 of them told us that they're not allowed to swim. Because other patients have also told them, but also other nephrologists and other nurses said, no, it's best not to. But we would say, do what you want. And if swimming is important to you, do that.
So, but the advice is exit site care after, and a device that covers the catheter and exit site, like a colostomy.
And most importantly, assess what you're swimming in.
Right. Okay, so ocean's okay.
Depends.
Well,
So if it's an ocean after a storm and it's churned up all the pollution that's at the bottom of your lake or your sea, then maybe not. So there's times at the moment, Adelaide, we've got a blue-green algae outbreak. No one is swimming in the thing, particularly if you've got a catheter. So it depends on the conditions as well.
okay, so ocean depends, pool depends, and then hot tub.
No.
I see hands. I see people be like, no hot tub.
ISPD, they're pretty, and I think Paul sort of said all the exceptions, but they sort of say, oceans, relatively clean oceans, and then well-maintained pools are reasonable.
No lakes. Clara, I see a lake. I see a lake in the background.
Yeah, I have a hard time with the lakes in Manitoba and Northern Ontario because so many people love to swim in them, and I think it would be really, really sad if somebody, if somebody didn't get to go back to their remote community because they decided not to do PD because they can't swim. So I'm going to say that we don't really know. I brush my teeth with my lake water. I don't drink my lake water. That might be the line, but we don't have that evidence. But the current guidelines are not fresh water. And Nikhil, I think, said it best when he said, if you can drink it other than ocean water, then you could probably swim in it. Although that doesn't count for pool water either. You shouldn't drink pool water. So.
But I guess this is where the lake is the ambiguity. And again, I think we still have to tell our patients that there's risks to everything we do.
Yeah.
I have patients that do non-PD activities that I consider risky, like ride motorcycles and do other sorts of things. So I guess it really is a per patient discussion about risks versus benefits. Can I tell you that there's been a lake peritonitis study? Not that I know of, and
yeah, exactly, yeah.
And not all lakes are created equally, right?
I think the important thing is exactly what you said is, if they are going to swim, they really do need something to cover it and need to care for it afterwards, care for the catheter exit site afterwards. And so it's really important not to say absolutely no, you can't swim, because they will never speak to us about doing it. So,
now maybe I'll ask you, Paul, you mentioned like a colostomy type bag. Is that the ideal, or can we even in the future come up with something even better, specifically geared to PD, or does it do a pretty good job and sort of no need to make any improvements on that?
They're already out there. So there are quite a few companies. I know in Europe, I'm not so sure in Canada, Europe and the States and Australia, there are companies that already make Tenkov catheter ones, and you can just Google it as well. So they're already out there. You can get them online.
Yeah. And interestingly, just to bring it back to PDI, there was a study from Israel, and this might be overkill for routine, but there was a study from Israel that actually started using them for patients with showers and actually noticed a reduction in Pseudomonas exit site infections and peritonitis, if I'm not mistaken, but we'll have to go to the source to confirm it. But again, I think that it got me thinking too about, just showers have risks too. And of course, we haven't developed that. But I think it's a whole area of research in terms of not getting the exit site particularly wet, that it's interesting to look at. Nikhil, you had an interesting case you wanted to share with us.
Yeah, there was a nephrologist who called me and said, hey, he has a patient who desperately wants to do PD, but he's an avid scuba diver. And he wants to scuba dive with a PD catheter. And we went through the whole rabbit hole trying to figure out what happens, including the physiology because of the pressure that develops. And it was an interesting study. Yeah, I think they did go ahead and get the PD catheter in. And I think that person continues to dive.
Okay. And again, there's scuba diving and there's scuba diving. They're not, when you scuba dive, you don't have to go down 20 meters. You can scuba dive. So it's that conversation that's really important.
Yeah, they're not looking for Titanic ruins, right? Now, Paul, I'm just going to ask you a question. So you have a patient who's an avid swimmer 5 days a week. And I know our former editor-in-chief of PDI, Martin, was at least I think when I last spoke to him, he was swimming pretty regularly. Is PD okay if you're going to do this every day and you're going to swim every day, do laps for exercise? What are your thoughts? And we're not talking about your summer holiday type deal. We're talking about someone who's really passionate about swimming frequently.
It would depend. I'm not an absolute no. For certainly, it would. How much is it important? What are the options? How long are you going to be on PD? I think you need that person in front of you. I struggle with cases and say yes, no, yes, no. So I think it depends. For me, it's a depends.
Yeah.
I just know that it is important to a minority of people, but I also think it's an area for research that we should really dive into.
No pun intended.
And get our and just really ask patients and to answer your question, how many actually do swim in the end, and how many don't because they've been told not to, and those questions haven't really been answered very well.
Yeah. So, we still need to study swimming, I think, and just really quantify the risks, really. We're telling our patients not to do something, and none of us, I think, really, truly know what the risks are. Stephanie, maybe I'll ask you another issue in the nitty-gritty of it is lifting. How much for exercise, dry, hernia risk factors. I mean, the whole idea is, and again, this comes back to Paul. We're not talking about the new catheter where increasing intraperitoneal pressure early on with a healing catheter may pose a different set of things we need to study. We're talking about the well-healed catheter, hopefully well-healed now, and what we tell our patients about lifting. I mean, I'm signing incessantly work modification forms about like what people can and can't lift, and they're like I have to commit to a weight for these like workman's compensation type things, and I sometimes I feel like I'm making it up because I really don't know what's safe and what's not, and I know, it obviously depends on the patient risk factors for developing hernias and leaks and whatnot. And of course, we have to evaluate each patient independently with those risk factors. But what's your sort of general gestalt to lifting?
Yeah, it's a great question because you're quite right. We are making it up. We're all making it up, right? To show that with the survey that people are making it up. Some people have no restriction. They're the minority, but generally it's in the range of what, like anywhere from 15 to 40 pounds we're telling people is the limit. Our program's 25. How we came up with that, again, nobody knows.
Right.
And what's crazy about it is that it's like, if you think about that, like that's quite relative to somebody's body size. So if I've got a 60-kilo old lady, I mean, when's she going to be trying to lift up 25 pounds?
Right.
And the other thing is too, we always just tell them not to overdo it and not lift anything too heavy. We're quite discouraging. Like the messaging is really, just be careful. This is fragile, and it really promotes fear. So I think the absolute cutoffs, they're really not valid. And like the opposite, right? You can have a 90-kilo guy, a roofer, and you're telling him, 20 pounds. Maybe he's not overweight. Maybe he's not a smoker. Maybe he doesn't have all the other risk factors. And so, it's a one size fits all. So we have the cutoff of 25. And if you want to do anything that increases your intra-abdominal pressure greatly, so things like heavy weightlifting, certainly conventional sit-ups, I mean, those can really increase the intra-abdominal pressure. We say you should be empty. And I think for activities like that really like somebody's a heavy lifter, and want to do like crunches for whatever reason, there's plenty of other things they can do for their abdominal strength. We would say be empty, right?
Yeah, and I try to make sure that at least they're dry if they're really committed to going and lifting weights in the gym. Clara, you were going to comment on that.
Just, I think Stephanie's example of the roofer is really important. We are impacting people's employment, so what I often say, and I actually think it is very relative, and it's relative to what you've done before. So if you are a construction worker or a carpenter or a builder who's lifting, 50 to 100 pounds prior to getting your PD catheter in, well, your weight limit probably isn't 20 pounds, or, it's probably somewhere higher once your catheter heals. What it is, I don't know, but I take an individualized, which is what we're saying about everything here about an individualized approach. But I think it's very important to take that into consideration because it's people's employment. And if we are assigning things that limit them to 30 pounds, that impacts what they can do, and sometimes impacts how part-time versus full-time, what's offered to them, and those kind of things.
Right.
Just interject and say, and I also find it interesting that we don't teach people really how to lift, like don't Valsalva and things. Like we're so preoccupied with this lifting cutoff, but we actually don't, because how many times have you lifted something and you're like, oh, that was too heavy? I mean, you have to lift it first sometimes to figure that out. So let's teach people again, like how to live and how to lift and safely.
Right. And I think, Paul, you were saying that we asked them to lift these bags and boxes and stuff at home, which it may exceed some of our recommended lifting amounts.
And often they will be lifting them by themselves. We often think they're going to be with their, if it's with their partner who is healthier, but they're often going to be doing things by themselves because that person isn't going to be around all the time. And as Nikhil put in, is you want to be lifting your grandkids and your kids. That's one of the pleasures of getting towards older age, is that you have these wonderful things that happen. I think what's really important, as Stephanie pointed out, we don't teach anyone to do this. So I think part of our education should be around how you can get a stronger abdominal. So they're not going to be, they're not going to be doing these, incredibly heavy crunches and that, but how you improve those muscles, those really deep core muscles that are important for this sort of stuff, and that hold your abdomen together and hold the peritoneum together.
I'm going to go back a little bit and ask this group, what about patients who are contemplating PD? They don't have a catheter yet. Would it benefit them to develop a exercise program before they get a catheter in the first place, so that you don't try to teach all of this when they're already on dialysis?
I love this idea. And prehabbing, right? Like we're only thinking about that even for something like surgery for transplant, kidney transplant. We should be prehabbing for all of our modalities. We know that there's a marked decline in physical function when you start dialysis, any kind.
So Stephanie and Nikhil, that's the study that we're doing now. We're getting people a month before dialysis, and you can't really get them much sooner than that. We're finding it quite hard to get them a month, so it's usually 2 or 3 weeks. We're giving them counselling, and then we see them a month after, and then 2 months following that. So we're trying to do a prehab, perihab around that, and also to increase the focus on physical function. We talk to them and listen to them about what their goals are from a physical perspective, rather than a nutritional or other types of perspective. Right. Watch this space.
Yeah, I think that's really important. I mean, obviously, the earlier the better in the CKD journey. The other question I wanted to ask you guys, and maybe I'll start with Clara, is that, we have the GREX guidelines for healthcare providers for PD. What do we have out there for patients? So if I have a patient that wants to learn a little bit more about exercise and PD and the safety and what they can do, are there resources for patients right now?
Sure. Yeah. I mean, I think there's local resources. I think the Kidney Foundation of Canada and Kidney Foundation in the US also have resources. Global Renal Exercise Network has resources available as well. Are there documents or papers, not specifically for patients or people with kidney disease, but I think there is information out there. Again, there has been a paucity before, and I think it's, again, we feel uncomfortable because there wasn't a lot of evidence. The evidence is accruing. I think one of the things I wanted to say before, and I kind of dropped it in our conversation, is that there's a renewed interest in exercise. There, 30 years ago there was some interest in exercise, and then it dropped, and now there's interest in exercise again. And I think largely to some of the other people on this, due to some of the other people on this podcast, there's been a shift in the focus, and I think that's what's made it so enticing now. Is it's shifting from like these lab-based measures that we're studying to actually clinically relevant, patient-important outcomes that are demonstrating that there's really important things that exercise can do that nothing else does, that we haven't found a solution for with medicine or with anything else. And so I think that's why some of this information isn't yet available, because for patients, because we're just gathering the information now and we're trying to disseminate it. It's just getting to the point where hopefully it'll become ubiquitous and people will have that information.
Yeah. Paul?
Yeah, several nephrologists and nephrology nurses have told me they just print out the guidelines, and if someone's contemplating PD, they say, "Here you go. Here's the guidelines, and do what you want with them." They're in English, they're in Thai, and they're in French.
And they were written from the perspective of a question that a person with kidney disease, a person on dialysis would ask. So
yeah. So it doesn't cover everything, and it clearly doesn't have evidence for everything, and the evidence is mostly very poor. But it's a consensus, and it helps develop the questions. So I was told at the last ISPD meeting, Paul, yeah, we've got your stuff. I have a bunch of exercise guidelines on my desk, and when I'm talking to someone, and I just give it to them, and they can take it away and read what they want.
Right. And I guess to that point, it might be helpful, at least for some of my patients, to have a sort of one pager that we could make sure was simple enough that people could understand at a more basic language level. So I think that would be a really great resource. If I could say, here's a one pager, there's obviously more detailed guidelines that you could have a look at, but you are right. And I think for many patients that are interested in exercise, the guidelines are just as much for them as they are for us. And I think, and I said, Nikhil, you had an idea about an infographic in every unit you were just mentioning?
Yeah, it is something that I believe people have been waiting in the waiting rooms, waiting for the physician to come in. That is a captured opportunity that we should capitalize on, where people can read stuff and QR codes and stuff. That will be really helpful. And videos. Many times doing an exercise the right way, maybe a video demonstrating that, these resources could be built.
Yeah. And I think, just putting some educational video content out there, and even a patient-faced webinar or podcast about this. Stephanie, you had a question?
Yeah, I'm just wondering, like for Paul and Clara, because Nikhil and I are in the same program, do your patients, when they start, do they get a binder of all this information, like hard copies of what to do in this scenario and X, Y, Z? Do you guys hand that out?
I'll talk to that for a start, because we asked that question to patients around exercise in our interviews over the last couple of months. And they said, yeah, we get it all. We don't read any of it. And there's so much. There's just so much. And of course, everyone learns differently. But really, we do need to be careful about the overload information that they get. There's just brochures that are in the pamphlets that are that are thrown into the back seat of the car. So I think we need to think carefully about that. And each different person will respond to different types of educational material.
And Clara, I was just going to say, I'm on the kidneyhealth.ca, Kidney Health Manitoba page on fitness here on the internet, which is really impressive. Do you want to tell us a bit about it?
Yeah, I mean, I think we purposely don't hand it out with the start package, because in any of our units, so whether it's our advanced kidney clinic or home dialysis, because it is overwhelming, and people don't remember that they got anything. But we do have, Nikhil, we don't have an infographic, but we do have all the handouts for the different programs that we have related to physical activity and exercise in all the waiting rooms. And then we have it available, have all that information also available on the kidney health website site in fitness and wellness, and we do have some exercise videos of things you can do to strengthen, and exercises you can do at home as well. So, but I think that Edmonton and Alberta may have some similar things. So I think and BC Renal also has some exercise internet information. So
Yeah,
I think it's out there.
BC Renal,
Yeah.
great. All our stuff is still paper. And I'm torn about it, because we were asked as an exercise program to contribute a one-pager to this hard copy binder. And, for me, I actually felt like that was a you've done come up. Like, we're acknowledging you as a multidisciplinary collaborator, and we're including you in our binder. So I was actually happy about the invite, but there was that sentiment, they get so much information. But the flip side to that is that, well, isn't that a double standard? Like, why is this the piece of information that's overwhelming people? And is maybe some people are reassured by being able to maintain, it's always this double standard for exercise. It's like, no, that can wait, or that's not important. Do you know what I mean?
Yeah, for sure.
That's a really good point,
Yeah.
Stephanie. And I think it's really important. And I don't know, I think, I have this one quote from a patient that when we first started an exercise program, saying, just because I'm a dialysis patient doesn't mean I can't do anything else. And I think that exercise provides a lot of people who have this huge life change with control. It's something that they can do. They do for themselves. It makes them feel better too, but it takes them outside. And so maybe we need to, as the people running the programs, highlight that it is as important. And sometimes, obviously, we don't do as good a job as we should.
No. And again, Paul's mentioning that there's obviously the GREC's website as well that has a lot of really important information. That is also another resource.
Jeff, what I'll do is I'll add all these websites to the show notes so that we can disseminate all of that on our social media channels too.
One final thing as we wrap this up, and this has been a really great discussion, research in the future. We as a PD community have a paucity of randomized controlled trials. I think that we would love to collaborate together. Canada and Australia have a long history of collaboration, and obviously we'd like to involve other countries as well. What is the dream study in this space? Is there a dream study? So you've got a donor who's going to give you $1 bazillion to do your dream research study in exercise.
So, very briefly, we know it's in 99% of people, it's a positive thing. It's how do we get it into programs? It's the application piece, it's the implementation science piece that we've missed, I think. We can prescribe all we want, but to get people moving more, and that's sort of our mantra, just get people moving more, is something that we still need to do. And the fear from both clinicians and patients in the PD space is the big thing, and to get over that fear, which requires education and all the other aspects. So it's that implementation piece.
Right. How do we actually get it operational in a PD facility with all the barriers right now? No, I think that's a really important point. Clara?
I actually think the DREAM study is a study that's large enough in PD particularly, but in dialysis in general, to show benefits to things that the healthcare system will care about, which is costs. So hospitalizations, cardiac events, and that's going to be really, really hard to do. But I think that's actually the study that would need to be done to help with people being excited about implementing these programs and being willing to pay for them.
Right. No, that's also really, really important. Stephanie, your dream study?
It would be a adaptive trial, randomizing people to interventions that are tailored to their particular frailty deficit. So we all know frailty. I think we have some of the frailest people that we look after, and it's multidimensional. So if you can tailor an intervention on the outcome of frailty, right? So we look at all these other surrogates like walking and things like that. But what about something like long-term care placement as your final outcome? Because I think that does matter a lot to people, staying in their own home, remaining independent. So that would be nice.
Yeah, no, and I think that's very true. People want to be independent without pain and with as much function as possible. And it seems to me like exercise ticks a lot of the boxes to help people get to that goal. So I think that's really insightful. Last comments from everybody. Any final thoughts to our listeners? Paul?
Yeah, I think there's a notion that exercise is something added on that should be fundamental. It doesn't help when you've got health systems that exercise as an inducement to maybe come to another dialysis clinic or another service. So there's lots of barriers that we've got to get over. So I think we need it as a mainstream, and we need exercise professionals in our services.
Yeah, I really think that that's a real gap. I agree. Stephanie, final thoughts?
I can just only agree with Paul. And, it's in our wheelhouse. I guess that's the other thing. It's in our wheelhouse. Like, it's in cardiology's wheelhouse. They have rehab programs. So does pulmonary, so does cancer. Like, we're dealing with a chronic, debilitating long-term disease. We have to rehabilitate our people. So I agree with Paul. We need help with that.
Clara?
Well, I'm going to quote Dr. Stephanie Thompson from a prior presentation and say it's not just a healthy hobby, it's a medical treatment.
Right.
For
very
problems.
True. Very true. And in Paul's waiting room in his PD clinic, there's probably people on, treadmills and stuff.
I wish. I think in Clara and Stephanie's there are.
No, thank you. That's been really great. All right. Well, this has been really great. I'm sure the conversation only begins here. It doesn't end here. And we really look forward to seeing more research output in the area of exercise in PD. I think this has really, for me, been something that has opened my eyes, and I'd like to explore a little more in my own area what resources we have, what we can start to do. We have our patient education session that we run in the evenings once every couple of months with our patients, and I think exercise might be one of the topics that we're going to talk about in the future. The other thing I was thinking about, and we can talk about this offline, is the Kidney Foundation of Canada, at least, has a walk locally in every area, which is great because it's exercise and raising money for kidney disease. But how can we send more education about continuing an exercise as part of our prescriptions for our patients' well-being, and use the kidney walk as a launching point to do that? Something that's sort of wheeling in my mind. In terms of an exercise campaign and awareness to our CKD patients. So thanks so much, guys. This was really great. And I really appreciate the time you guys took to do this.
Thanks for having us.
Thank you so much.